I thought one of the subjects that always bears discussion is that of failed hammer toe surgery. Correction of painful and bothersome hammer toes is obviously a common demand in the practice of podiatry, and unfortunately not all hammer toe surgery turns out well to the patient's satisfaction. And over the years I've, like others, had my share of patients who've been less than completely satisfied with the outcome of their hammer toe surgeries, although the majority of the patients seem to be reasonably satisfied. There are many approaches to the correction of hammer toes, and the particular approach that's appropriate in any given patient is obviously dependent on the circumstances in that patient. For example, in the diabetic patient with distal ulceration, many times a flexor tenotomy is appropriate given adequate vascular status and serves the needs to adequately reduce the deformity present, remove pressure from the toe, and resolve the ulceration. Sometimes tendon transfers are required, particularly in those patients that have a very significant flexible forefoot equinus deformity. In some patients, arthrodesis is appropriate. In some patients, shortening metatarsal osteotomies are necessary, or plantar plate repairs as part of the correction. So that there are, again, many procedures that are available to us, and all of them are appropriate under certain circumstances and sometimes perhaps not appropriate under others. Now, when we have failed hammer toe surgery, people also will frequently go for additional opinions, and it's very easy in hindsight to look at the failed procedure and comment that you, in hindsight, would have done X, Y, or Z. So we do see procedure failures, not so much complication, but procedure failure. And the question is, does any one approach actually reduce the incidence of procedure failures in the correction of hammer toes? Procedure failure generally means recurrence of the hammer toe deformity, or persistence or less than total correction of that deformity with continuing pain. We have sequela of hammer toe surgery, and this will include the fact that many of these procedures result in shortening of the toes. They can result in lack of purchase of the toe, and especially when arthrodesis or fibrodesis procedures are utilized, there is stiffness of the toe. And then we have some complications. These would include things such as vascular compromise, persistent edema, and nerve injury. Not infrequently, we are called upon to perform a revision surgery for a patient who has undergone prior correction of a hammer toe with less than ideal outcome. And patients need to understand that in doing corrective surgery for a failed hammer toe, there are going to be limits to what we can and cannot do. And we may not be able to establish full purchase or full range of motion. We may not be able to restore length. There are many decisions that frequently need to be made when doing revision surgery for a hammer toe, and those goals need to be determined and discussed with the patient, and the patient needs to be accepting of those goals for the revision surgery. Not infrequently, the major goal is restoration of pain or reduction of prominence of the deformity. When we're working on toes, on the other hand, there are certain confounding problems that have to be considered. This includes the fact that we're working in a small area with less than massive amounts of tissue, so that following revision surgery, persistent edema, neurovascular problems, the development of scar and stiffness, or vasomotor changes are not at all uncommon. And generally, if possible, after revision surgeries, we want to get that patient mobilized whenever it's appropriate and get them mobilized as quickly as we can. Now, we see lectures on how to perform revision surgeries for hammer toe surgeries which have been unsuccessful. And we all know as experienced doctors that what one does in any individual case is absolutely dependent on the individual circumstances. And it's difficult to produce a paradigm, a flow chart that is all-encompassing for the many variations of less than successful hammer toe surgeries that can occur. Many years ago, I received 2 inquiries from plaintiffs' attorneys in the same week, and both of the suits involved a hammer toe of the second toe. One case was from Illinois, in which a podiatrist had a patient with a hallux valgus and a second toe hammer toe, which was painful. The podiatrist determined that it would be difficult to maintain correction of the second toe without reducing the hallux valgus, and went ahead and corrected the second toe hammer toe and also corrected the hallux valgus with an Aiken procedure. The patient developed a non-union of the Aiken procedure, and the doctor was being sued because the patient's primary complaint was just the second toe. The patient had a non-symptomatic hallux valgus, and the doctor performed surgery on the non-symptomatic hallux valgus and was being sued for unnecessary surgery. The same week, I literally received a case from the state of Missouri, which was the converse. It was just absolutely diametric. The patient had a hallux valgus and a hammer toe of the second toe, and the podiatrist elected to just correct the second toe because the hallux valgus and bunion was not painful. The patient went on vacation in Europe shortly after the surgery, developed recurring pain in the second toe, returned to St. Louis, and the patient was told by a subsequent treating doctor that the hallux valgus should have been corrected at the same time, and the patient was suing for not performing a hallux valgus correction to allow adequate domain for reduction of the second toe. I looked at both of these cases and determined that what we needed was a single courtroom, have everyone gather in that courtroom and have some jury decide which way we should go. Should we reduce the painful second toe without the non-painful hallux valgus being addressed, or should we do just the opposite? So decision-making is quite individualized from case to case. When we talk about correcting failed hammer toes, again, this is individualized to the circumstances. Over the years, however, I think I've developed a feel for what I would consider to be situations, clinical situations, where there's a greater risk for failure, and I believe that most observant and experienced podiatric physicians and surgeons have that same feeling. The great golf instructor Harvey Penick, who's most known for his famous Little Red Book, a series of vignettes regarding lessons to be learned in learning the game of golf, talks about a student who was willing to pay him a substantial amount of money to learn how to get out of a sand trap, get out of a bunker. And he was famous for having told that individual, "I will teach you how to get out of the sand traps, but first I must teach you how not to get into them in the first place." And it's similar with revision surgery. There are no procedures that will guarantee success, but certainly with experience, one starts to recognize clinical situations that are higher risk for failure and sometimes almost demand an expansion of the hammer toe surgery beyond just the toes themselves. And this is something that needs to be explained in detail to the patients. For example, we know that patients with metatarsus adductus are not going to have ideal alignment in the transverse plane when we correct hammer toe deformities, because the metatarsals are adducted. And if we were to properly align the digits with their metatarsals, we'd have toes that are pointing inward. So certainly that's a difficult problem that tells us higher risk of failure, so that yes, we can reduce these deformities satisfactorily in the sagittal plane, and likely maintain that correction with an arthrodesis of the interphalangeal joint, but maintaining transverse plane correction will be difficult. Elongation of metatarsals. Again, if we have an abnormally elongated metatarsal, we know this is a circumstance that's going to be associated with increased risk of failure, and we have to determine whether it's necessary to come proximally and perhaps initiate some surgical management of that elongated metatarsal. Any type of significant equinus deformity, whether it's equinus deformity at the ankle joint or equinus deformity in the forefoot, whether it's flexible or rigid, is going to be associated with soft tissue imbalance and a significant risk for recurrence of sagittal plane deformity. Severe pronation deformities. We know that in a pronated foot, we have malalignment of the forefoot and hindfoot. We know that as a result, we have instability. We have intrinsic muscles that fire at an earlier time and at a lower intensity and somewhat out of phase. And we know that as a result, we have hammer toe deformities that develop. Certainly, cavus foot is an example of a deformity in which hammer toes are a part of a more global process and more global deformity, and our likelihood of maintaining successful correction over the long term is going to be difficult. Neurologic disorders, perhaps the most commonly encountered would be that of the intrinsic minus foot type in the patient with diabetes and motor neuropathy. We see hammer toe deformities and digital deformities in spastic deformities such as cerebral palsy or status post-stroke, and in lower motor neuron disease as a result of, for example, peripheral nerve injury. We have the effects of adjacent deformities, and again, the most common example would be the patient with a hallux valgus and bunion deformity, who's relatively non-symptomatic with regard to the bunion, but has a symptomatic hammer toe, and the question becomes, do we need to reduce the adjacent hallux valgus, or perhaps a symptomatic second toe with an underlapping third toe? And obviously the patient's overall medical status, the patient's overall vascular status, the patient's gait stability or instability, all of these things are going to make differences in the determination of the appropriate procedure. And we sometimes see some difficult situations, such as this common scenario where we have a hallux valgus and a bunion. We have some adduction of the second toe. We have some relative elongation of the second metatarsal. But the patient's only complaint is that of the painful corn on the second toe. And so the question becomes, A, how much surgery is required to correct just the second toe? And B, what is the likelihood of maintaining that correction over the long term? That is why this concept of limited results is so important, and having the patient understand that while they are presenting with an isolated toe that's painful, that their toe is part of a more global deformity. And I find it very helpful to openly discuss this with patients, show them their x-rays, have them understand the nature of their deformity, and have them share in that decision-making process. Or situations such as this, where we have a hallux valgus interphalangeus deformity, a slight hallux valgus, a small bunion, some degree of first ray medial positioning, and relative elongation of the second and third metatarsals. So we look at each patient individually, we look at the components of their deformity, and we try to make a best guess, but we don't get them all right. And just like professional golf, even the professional golfers who hit 1,000 golf balls a day for practice end up in a bunker on just about every round. So are there clear decisions that will be helpful? And the answer is we really don't know. This was a recent study published in Foot and Ankle International looking at hammer toes with a rigid proximal interphalangeal joint, and they compared patient satisfaction with arthroplasties versus digital arthrodesis. And in the end, although the arthroplasty has become vilified, the classic post-arthroplasty, and We more or less teach our residents more and more to go ahead and perform an arthrodesis procedure with or without retained implant material, with perhaps the exception of the fifth toe. The fact is that while the arthroplasties may not look quite as straight after 1 year, there may be still some residual minor deformity. Patient's perspective of the outcome was no difference between arthroplasty and arthrodesis at 1 year. Now, what about devices to maintain correction? We have seen a condemnation of Kirschner wires, and most of this condemnation, I believe, has been industry-driven, suggesting that there are patients that are just fearful of having Kirschner wires placed or removed at some point, that there's an extraordinarily high rate of infection and complications and wire breakage associated with the use of Kirschner wires. Here's a relatively recent paper looking at over 2,500 hammer toe corrections with Kirschner wire fixation. And you can see the actual incidence of complications with Kirschner wires are relatively small. Only 3.5% of patients required a revision surgery, and the infection rate extremely low, less than 2%. And overall satisfaction rate high with the use of Kirschner wires. Here's another study looking at length of Kirschner wire placement and whether or not longer placement of Kirschner wires, such as 6 weeks for treatment of hammer toes, is associated with increased incidence of complications. And as you could see, the prolonged use of Kirschner wires for as long as 3 months was not associated with, 6 weeks, was not associated with any increased risk of complications. We hear much about breakage of Kirschner wires. Here a look at over 1,000 Kirschner wires placed in about 565 patients. These are 0.45 Kirschner wires for hammer toes, and of these, only 33 were broken in 27 patients. The fractures occurred only in patients with wires crossing the metatarsal phalangeal joint, and those with use of smaller Kirschner wires. The suggestion in this study being that you want to use a 0.45 Kirschner wire, and again a failure rate of about 3.2%. Now, we've seen a tremendous amount of marketing for the use of implants rather than Kirschner wires, because implants are presumably associated with a lower rate of complications. Here's one such study looking at 117 toes evaluated over 3 years, comparing Kirschner wire fixation versus, in this case, smart toe implants. And as you could see, there was no difference in malunion rate, fracture rate, non-union rate, or need for revision surgery. And in fact, fracture rate was higher utilizing digital implants than Kirschner wires, and union rates were higher using Kirschner wires than using digital implants. We know that floating toes can occur following performance of digital surgery, and generally with such floating toes, which is a common complication, a lack of purchase of the toe, the general options are going to be flexor tendon transfer, arthrodesis of the interphalangeal joint if that was not previously performed. As we know, arthrodesis of the interphalangeal joint will increase the efficiency of the intrinsic muscles attached to the toe. Generally, some type of scar release and soft tissue release is going to be required to metatarsal phalangeal joint. A Z-plasty or V to Y advancement flap is frequently indicated for severe scar contracture when present. And when we utilize Kirschner wires, we generally want to cross the metatarsal phalangeal joint. Now, as Mr. Pennock would say, we want to stay out of the sand traps rather than get into them. So what are some of the ways we can do that? I think it's important to avoid distal metaphyseal osteotomies of lesser metatarsals when they're really not strongly indicated. And as someone once said, is the 2 millimeters of shortening that you get worth the headache that you potentially get with the Weil osteotomy? We know that floating of a digit is very common as a complication following distal metaphyseal osteotomies of lesser metatarsals. So I think some significant consideration should be given before proceeding with the Weil osteotomy as part of hammer toe correction. It's also important to properly position toes with the K-wire. If we have toes that are malpositioned, such as in this particular case, we can't blame the Kirschner wire for the failure. This is a surgeon's failure to properly position the toe. We want to try to maintain soft tissue balance at the time of the initial surgery, and again, consider the effects of the adjacent tissues and correct adjacent deformities when it's required. Shortening of the toe is also a difficult procedure or a difficult deformity to deal with following less than satisfactory digital surgery. Frequently, this involves arthrodesis with a Kirschner wire or grafting. Generally, soft tissue release is required to allow stretching of the contracted soft tissues. Tendon lengthenings are frequently required. Arthrodesis with grafting typically is required to gain lengthening. Most of the digital implants really don't provide for adequate shortening that may occur as a complication. What about amputation of a toe? This is particularly attractive, I think, in the elderly patient who has multiple concurrent deformities and would require a good deal of surgery to correct an isolated hammer toe. We come to the decision of whether or not we need to reconstruct much of the forefoot. For example, the patient may have an underlapping third toe, have a hallux valgus and bunion deformity, or have isolated complaints involving just the second toe. This was a small study looking at simply telling the patient they'd be best served by amputation of the toe, and you could see that the majority of patients in this study, although small, would have the surgery done again and were content with simply amputating the toe. Here again, over the years, I've found that discussing this with the family and with the patient, getting them to understand that the patient is essentially ambulating without the toe on the ground to begin with, because patients are frequently fearful about losing balance, and you show them that, look, you've been walking without this toe on the ground for quite some time. The real difficult revisions are cases such as this, where there is a complication involving implants, particularly when there is overgrowth of the bone and we have true fusion. These can be very difficult revisions and can be associated with quite a bit of postoperative swelling. In this particular case, the patient had a painful third and fourth toe. In placing the implant, unfortunately, there was a fracture at the middle phalanx, and the surgeon in this case elected to bridge the middle phalanx and use the implant between the distal phalanx and proximal phalanx. The implant itself fractured in the third toe. The patient was never actually informed that these complications occurred. She was led to believe that the surgeries had gone well. The patient was dissatisfied not only with the shortening of the toes, but also the pain and the swelling associated with these failures. And again, these are difficult revisions for which we don't have firm guidelines. Redeformity and recontracture, again with fracturing of implants, is not a rare occurrence and does occur in a not inconsequential number of patients. So in looking at patients who are going to undergo digital surgery, in undergoing revision surgery, it's important to look at all of these factors to do surgeries that you are comfortable performing, to have the patient have a full understanding of the options that are available and are not available to them, and generally playing with the clubs that you can control. Looking at implants, for example, this particular study showed, looking at the Stayfuse implant, the diffusion rate was actually quite low. It was only 60.5%, and the overall complication rate was 55.3%. And certainly those of you who utilize K-wires on a regular basis know that you do not have a 55% complication rate. So the question you have to ask yourself is, do you need a digital implant? Again, these are difficult revision surgeries when they fail. Persistent edema, shortening, and pain are common. Removal of the implant, again, can be a very difficult procedure. Frequently, you have to resort to autogenous interpositional grafting and a good deal of soft tissue correction. So, take hammer toe surgery seriously. You need to evaluate the patient globally and not just focus on the individual toe. I think it's very important to set specific goals and objectives with the patient and their family, and in many circumstances, hopefully everyone will be satisfied with limited results, and that is resolution of pain, improvement of the position of the toe, but not necessarily a perfect end result. You need to discuss the goals and objectives with the patient and their family. Utilization of good operative technique is, of course, important, as it is in any surgical procedure. You want to think about avoiding unnecessary costs of implants, and you want to make sure that you maintain proper positioning and proper splinting following surgery, because postoperative care is very important in these patients.